You see that flap of skin there, Billy?
Yeah.
That needs to go because it never really regresses. Well, maybe it does, but it certainly regresses a lot quicker if we give that a little bit of a helping hand. And then that's that done there. So that's our little hypergranuloma. If there is. Here's a young man that presented with quite a bad ingrown toenail of about 12 months duration and presents with quite a lot of hypergranulation tissue. And there's also an underlying medical condition that makes him somewhat immunosuppressed. So there's two questions really here. Is what's the best technique for him? And do we need to do something about that hypergranulation tissue? As you'll see from my YouTube nail surgery playlist, I'm quite a fan of incisional techniques. And this patient was referred through for a Winograd. However, given that the nail was somewhat mucky, I really don't like to sew in an infection. Yes, he was immuno-compromised, but I always try and look to see if we can manage that and do a phenol technique because I ultimately think that they work better than an incisional or rosadic procedure. I think they're a bit more predictable. So in this particular instance, we managed the immune status, which actually meant taking him off some anti-TNFs, and we went forward for a traditional nail surgery procedure with phenol, with resection of hypergranulation tissue, which I also like to do. This is my edit point. So Billy, first thing we're going to do is just give you first off just a little skin prep for the anaesthetic. Going to be 2 injections, base of the toe, and we'll make you nice and numb before we start. And we're yeah, it's really quite swollen, isn't it, Billy?
Someone have a toe growing out of it.
Yeah, it almost looks like that. So Billy, I'm just talking to the camera a little bit, so I'm just going to use standard hypodermic syringe. This is Luer lock. We've got some narrow pin in. Take the air out. 23 gauge blue needle. Billy, scratch. 3, 2, 1, scratch. Little sting as it goes in. How's that feel?
All right.
Little sting at the bottom. Feeling that?
Yep.
Scratch again. 3, 2, 1, scratch. Sorry.
Sort of moved.
Yeah, that's okay. And then I'm just going to run a little bit over the top, just because I can. That's coming out the skin. I'll edit that bit out. And that's the injection done. So now we wait a little minute for it to go numb before we start, he says. Okay, start again. So Billy, we're just going to test for sensation now. So the question is, sharp or blunt?
That's sharp.
Still a bit sharp there?
Yeah.
Okay, what about here?
Still a bit, yeah.
What about here?
Fine.
On this other side, although we're not bothered about this other side?
Can't feel anything there.
Okay, so it's about halfway there. When I get these situations, I'll often do just a little bit of massage just to help the local anaesthetic swish round a little bit. Got a little bit of claret there. Change these gloves. Next up is some skin prep. We're going to use just a little bit of iodine. I've already checked with Billy that he's not got any allergies, particularly to iodine or shellfish. How's that toe feeling now, Billy? Is that feeling more numb now?
Yeah, you can just feel it moving, that's about it.
Just feel it. Yeah, so the way the anaesthetic works, you're a bit too young to find this funny yet, but it works a little bit like a divorce. Takes away pain but still leaves some feeling, okay? So that was numb before. How are we doing on the side now?
Bit of pain there.
A little bit sharp there still. So it takes a little while to work, and it's because of this inflammation and infection, it's coming up the local anaesthetic from working. So on a scale of 0 to 10, how does that feel now?
That's still very sharp, yeah.
Still very sharp at the end, okay. So this is quite good for real-time nail surgery procedures. You can really see that we're struggling to get this numb, and it happens. So if we're not numb at the end, it's really the plantar nerves are not fully numb, so we'll put more in on the plantar side. So you shouldn't feel that too much, Billy. So I'm going to put more in at that plantar lateral nerve, because that's the one that we really need to target. And then we'll just kind of work that round. Is that still on camera, Sharon? Can you still see it? Still nicely in. Is it still flashing red? Camera still working?
Yeah.
All right. So Billy, if this doesn't work after this, Sharon and I are just going to go for lunch and then come back in about half an hour.
That's alright.
Is that okay?
Don't worry. I can't move anyway.
We can, but you shouldn't.
I can't feel much movement with, like, foot to the
Okay. How are we doing there now?
dead.
Hurrah. Okay. We've got these nice new nail surgery packs. Haven't quite worked out what that button's for. So I like to do it the old-fashioned way. There's probably a course out there. So Billy, we do it under a little tourniquet so there's no bleeding. Sorry Sharon, my other arm's in the shot there, isn't it?
Yeah.
Okay. Push that back. Are we still nicely in shot, Sharon?
Yes.
Awesome. So we'll just use a little bit of an elevator and we'll just double check the width of the nail. Also helps us confirm that the patient's nice and numb, because patients wouldn't normally let us do that. So Billy, half an hour ago, was quite sore. Here's our weights. Here's some Spencer wells or mosquitoes. So the secret is to grip nice and proximally on that nail. Grip and then rotate. We'll see how wide that plate is. So that's pretty wide actually. So Billy, you had to be treating your nails before, done a really good job with the nail. It just goes a long way down the side. So quite a wide section of nail. And then this is the thing really that's going to get you the best cosmetic result in the long term. You see that flap of skin there, Billy?
Yeah.
That needs to go, because it never really regresses. Well, maybe it does, but it certainly regresses a lot quicker if we give that a little bit of a helping hand. And then that's that done there. So that's our little hypergranuloma, if there is such a word. I might have just invented that word. Okay, we'll get rid. And then we just want to check that there's no nail plate left in there. Nice and clean. And then 3 minutes, Sharon, you on the clock, 3 minutes of our favourite caustic. And you can see the tissues are changing from pink to silver, and that's the phenol doing its thing. So Billy, we were talking about the nail surgery before and how we put the acid on. This is the acid, and this is what gives us the 90%, 95% chance it's not going to grow back. You'll get a bit of an acid burn from this. So you'll have a wound for anything from 4 to 6 weeks. Sorry, my hand's in the way of the camera, guys.
4 to 6 weeks.
4 to 6 weeks, you'll have a little bit of a wound. And this is why my colleagues in podiatry line were a little concerned with your medical history, because you're a little bit delicate, not to give you an open wound for that period of time. However, if you look at this toe, you'd had this for, what did you say, 18 months?
Yeah.
You know, and it hadn't healed. And with the medication that you've been on, you've not gone on to get, you know, a massive infection or a septicemia. So I normally argue it's a little bit of over caution. So having dealt with the nail, the infective process is out of the way, and now you've just got a bit of an acid wound to heal. First couple of days, it'll be a bit leaky. We'll see you back for a change of dressing, and just keep it nice and clean. Sharon, how's that for time?
Just coming up to 2 minutes.
2 minutes. So I like to quite aggressively work that in. Oh, quite aggressive actually. Don't know my own strength. Be going to the gym. Go to the gym 3 times a week, Billy. I only use one machine now.
Burn machine?
Yeah, the vending machine. And we'll get some of that cleaned out. So Billy, what will happen now, that will just basically just heal in, and you'll be left with a permanently thinner toenail. The other side's fine, we don't need to do anything for that. But that's really it sorted. Awesome. These are these chloropeps that I like, really nice for prepping. Normally get them going. And then this is what I'm just going to use just to dilute what's left of the phenol, give it a final clean. And that's it done. Sharon's going to put the top of the phenol for me, so that we don't all fumes tops on the side. Billy, we use a non-stick dressing, because you will get a little bit of bleeding because we've taken away that extra tissue. So we'll put a bit of a non-stick dressing on. This is an iodine impregnated gauze. Sharon's about to get a big old bandage for me. Sharon, are you covering off the bandage? So we put the dressing on before we let the tourniquet down, and then some slight compression. Sorry for the banging in the back, viewers. Sharon, do you want to open a few more drawers? I don't think you've looked in every drawer. Just check that bottom drawer again, Sharon. You know, the one that really slams loudly when it closes. And this is known as a Tom and Jerry dressing. And we're all done, Billy. Questions, sir? What can I tell you?